Hi, today's video snippet is on the script-focused hypothetic abduction. This initially looks like it's an algorithm or a clinical practice guideline, but we'll talk a little bit about that towards the end because it actually isn't. Just before we get going, let's look at a couple of slides on essential illness scripts. This is basically one on central low back pain, and all of the, well, not all of the possibilities it could be, but the more common ones that we're likely to see. Now, we're talking about central back pain, bilateral back pain, and pain going down the backs of both legs. So essentially, from that those symptoms, you must come up with a hypothesis, and the titles in blue are those hypotheses. So we'll just follow one of these and you'll get an idea of what we're looking at. So with those symptoms, one of the hypotheses must be, and it's probably the first one you should go to because it's pretty much the most serious one, is that this is an uncontained median disc herniation. So the disc hernia has herniated posteriorly and it's now hitting the cord requiner. So the illness script for the essential illness script for this will be severe back and bilateral leg pains, plus or minus neuropathic pain in both legs. It may not be there, it depends on how bad this pressure is, but the real risk is that it's going to be there at some time. These tend to be fairly large and they get large very quickly. Like all disc herniations, flexion and extension are seriously affected. You'll have obligate functional loss. Range of motion is limited and painful in all directions, and you'll see multiple radiculopathies simply because this thing is hit in multiple routes. Differential diagnosis could be a contained disc herniation, so this pain is not the neuropathic pain, but the somatic pain is actually coming directly from the disc, or it could be a spondylolisthesis that could be causing a cord requiner syndrome or not. And again, it depends on the sort of symptoms you need. In either case, or in any case, this needs urgent imaging. This is not something you should be playing with, regardless of whether you find neuropathic symptoms or not. You've got to look for the radiculopathy or the multiple radiculopathy, but even if it's not there, the threat is that this is going to become one. So this is basically the way these essential illness scripts work. And you can go back over this as many times as you want to. You can pause it and look at the thing. I'll just shift out the way of that one a bit. So if you want to pause that lower one, you can do. And I would suggest maybe having a look at this. But this is basically the illness scripts, the essential illness scripts for central low back pain. And it's likely to be one of these. Here's another one for post-traumatic neck pain. So again, this is posterior and posterior central pain in the neck. Now again, you've got all of the diagnoses, all of the potential diagnoses, hypotheses are in blue. So again, you can follow through on any of these. And if we pick the ARF, we go into the root of this being an ARF. This is basically a true medical subluxation of the atlanto-axial joint. It's an atlanto-axial rotary fixation. So you actually do dislocate this joint. And usually it's not the trauma in itself that's caused this. Generally speaking, there's an instability already present and the trauma actually managed to dislocate this. The essential illness script is posterior pain, central pain, and bilateral pain. There's an immediate torticollis. There's immediate loss of movement, so locked torticollis, obligate functional loss, and the game here is not doing an objective test. All by itself, that is enough to suggest that this is the pain central. this is enough to suggest a high cervical fracture or possibly this half. And these are your differential diagnoses. So again, this needs immediate imaging. And again, you can pause this. I'll get out of the way of that one. You can pause this and look at it at your leisure. I know it's probably not a bad idea that you do. Now, these illness scripts, we'll talk about this a bit more. I'm giving them to you, so you're taking my word for this, but the whole point of this exercise is so that eventually you start generating your own illness scripts, and if they disagree with the ones I'm giving you, you go with the ones that you've got. If you can argue for them, go ahead and do it. As I say, this isn't fixed in time or space. As your experience increases, you can disagree with these by all means. I really am not looking for agreement for the sake of agreement. So let's build an illness script, an essential illness script, shall we? And then we'll use it in the script, the SFHA, script focus hypothetic abduction. Now, it's not so much for building the essential illness script, we've sort of done that, but this is using it in diagnosis. So the first symptoms you get, the initial symptom, and you've got to overcome your condition here because you're reluctant to do this, but in fact, you do this automatically, you just manage to suppress it. Don't suppress it. If they've got lateral elbow pain, come up with a hypothesis. This isn't your fault. You're not locked into this. If you find different information that says the hypothesis is wrong, you move on to another one. You're not failing at this point if the hypothesis is wrong. The time you fail is when the diagnosis is wrong and the treatment's wrong. That's when you fail, not in this phase. So you generate H1. Now, if you're going on the bottom line, those blue rectangles, you're going to attack, and it really is an attack on the hypothesis, the first hypothesis, and you're going to attack it with the essential illness script. Now, you may have to go all the way through that essential illness script to say this isn't working, and you'll then move on to the next one. But you can't say it is working until the whole illness script is given, is used, and then you can say, okay, it more or less fits. And this is what you're trying to do, it's a better fit. So you attack it with the EIS. If this is working, the H1 is strengthened. You then hit it with the bias correction. If the bias correction works, then you attack the working diagnosis now, this is what it's become, with your treatment. And if the treatment works, then the diagnosis is correct. If this falls anywhere during that attack with the EIS, then you move on to H2. H2 is generated from that first symptom and all of the information you've got from your initial essential illness script. So EIS2 is born of EIS1, and then you do the same thing again. You attack it again with H2 and EIS2. And again, if this works all the way through, you attack it then with the bias correction, and then you end up with the working diagnosis, which becomes a diagnosis when the treatment works on it. If H2 fails, you do it again, and you do this HN times, and you attack HN with EISN. And if that works, there you go. Now, if none of this works, you're unable to make a diagnosis. So your best bet then is to ask somebody else to have a look at the patient and give you a second opinion on this. But this is the way you use the essential illness script in script focus hypothetic abduction. The whole point of this is to stop you becoming biased, becoming fixed on something, and basically never really running out of options until you run out of EISs. So let's do this for the condition. We'll do, the patient comes in right low back pain over on the left-hand side, that's square. Your hypothesis is segmental dysfunction. You attack it with the EIS, coming from the bottom up now. This takes you over to the right, the EIS works. The bias correction attacks the hypothesis. You move on now to the working diagnosis, which is segmental dysfunction. You then do a biomechanical exam. this, if it's negative, then your initial diagnosis, your hypothesis is wrong, but more likely it will be positive, and you'll come up with a defined segmental dysfunction. That will lead you to the treatment plan, which may be manipulation, whatever it is, but you need to get this thing mobile if this is what you're dealing with, or stable if you're dealing with instability. If the treatment works, then the diagnosis is correct. If the treatment fails, you revisit the treatment and you revisit the diagnosis, and if all that is failing, and basically at that point you need a second opinion or go back over the diagnosis if you know where the issue lays. Now, if the you go right low back pain and the EIS one fails, you've got new information, you'll go to H2, which we'll say is lateral stenosis. You hit the hypothesis with the EIS for lateral stenosis. That'll give you the working diagnosis of lateral stenosis, come up with a treatment plan, treat it, it works, you diagnose it correct, the treatment doesn't work, then you revisit the whole thing again. And up again, if the EIS for lateral stenosis fails, you go on to, or the treatment fails, you go on to a better hypothesis, and you do exactly the same with that. So this is a fairly straightforward system, but you have to overcome some conditioning. You've got to be able to make the hypothesis of minimal information, and you need to get out of it when you get another hypothesis that fits your new information better. It's really not terribly difficult to do. It's difficult to get out of that conditioning. So let's see what the script focused hypothetic abduction isn't. It's not a clinical practice guideline. It's not rote learning. It's not an algorithm. It's none of those things. This is simply a way of using clinical reasoning in a more efficient and economical manner. So this is clinical reasoning. It's based on minimal information. So this isn't the least amount you can get. This is the least amount that you need to make the diagnosis, but no more than that. The EIS you're given will be on, basically right at the moment, it's on my experience with the average presentation of the condition. So this is not going to identify outliers and very atypical variants, but you're not going to recognize them anyway because you don't have the experience just yet. We all expect you to generate your own EIS if you experience different presentations. Your practice may well be different than mine. And I've got no problem with that at all. If you come up with a different EIS, let me know and let me look at it, because if I need to change it, I will. You are also expected to generate the initial hypothesis. This is not as easy as I'm making it sound. You have to overcome the condition. You have to make the hypothesis based on that first symptoms. Let me get out of the way again. The EIS for that hypothesis, and you've got to be able to recognize when a better fit for the information you've got from that initial attack better fits a different hypothesis. So you have to change the hypothesis. And as I said, your instinctive feelings is this is failure. It is not. The more hypothesis you generate, the more likely at the end of all this, you're likely to be right, because you're generating more and more information, but you're doing it in a focused manner. So it's not becoming a confusing issue because you're throwing out stuff at the same time. Each hypothesis is hit with its own illness script. So you are gathering more information. It's much more likely you'll be right at the end of this than you will be on your first hypothesis. Nothing at all is wrong with that. As you go on and as you enrich your experiencing, we expect you to recognize outliers and atypical variants and enrich your illness script and eventually become basically a pattern recognizer. That's what we're hoping, and that's what we expect. So I hope this helps. And again, we can discuss this as much as you want to, because this is going to be the basis of what we do with you. Now, you don't have to keep doing this. The sooner you can get away from this type of clinical reason and get yourself into pattern recognition, the better. But you'll go back to this, because you have to go back to hypothetic deduction abduction in one form or another when you meet a condition you've never come across before, either because it's just a rare condition or because it's a major outlier. Now, if you come across a major outlier that you haven't seen before, your initial response will be to misdiagnose it. Actually, that's not correct. If you use this system, you'll mishypothesize it. So an atypical biomechanical dysfunction can look very much like a disc herniation. The atypical aspect of the dysfunction now is how acute the problem is. These don't occur very often, but they do definitely occur. So you get this major acute pain. Because the pain's acute, it refers more than you would expect it to. And because of the severity of the pain, you get obligate functional loss. So these things are not specific to a particular pathology. Mostly this is about how painful it is. So this will end up looking like a disc herniation, and it will only be when you investigate it for a disc herniation, when you apply the EIS to it for a disc herniation, you'll find that it's not there. The straight leg raise is probably going to be negative. It's certainly not as bad as you think it's going to be. So these things are not easy to recognize because you've never seen before. You can't recognize it, but they're also not easy to work around. And the real problem there is anchoring. This looks like a disc, and you're likely to anchor to it because this is what it looks like. So this stuff comes later. Don't expect to get this by the end of this program. You won't. This stuff takes experience, which takes time, and it takes reflection of your practice. But this is a good in. This will help train you for pattern recognition. Whereas when you're doing every single test you can do, every question you can think of answering, that actually works you away from pattern recognition. So it's interesting that we still keep teaching it that way. Anyway, I hope this helps, and I'll see you soon. Take care, everybody. Bye.